We'll give it a few minutes and let everybody log on. All right, can everybody see that? Are you all able to see the PowerPoint? Okay. Well, good evening, everybody. I'm Dr. LePage. Tonight, we're going to talk about childhood diseases, particularly ears, eyes, nose, and throat infections. Our objectives are going to be to identify the pathophysiology, etiology, clinical features, and those diagnostics, whether they be tests or signs and symptoms that we use to diagnose these problems. What are some of our treatment options, some complications, and then, of course, our nursing interventions. We're going to talk about otitis media, tonsillitis, adenitis, conjunctivitis, strabismus, allergic rhinitis, and epistaxis, which is nose bleeding. We always talk about prioritizing care and our nursing interventions and how we're going to prioritize those, and then how we treat these patients, and then incorporate those pharmacological principles to administering those medications for those same disease processes, and then, as always, evaluate the care that we render or that we provide to these patients. So, kind of clear cut and comprehensive. So, otitis media, it is most often it's acute otitis media because it comes on sudden a lot of times. It is defined as an infection of the middle ear, and it's the second most common pediatric disorder. So if you've had kids or you think about kids and work in an emergency room, that's what we see. And we typically see a lot of them in the middle of the night. They wake up with that really bad earache. We see a lot more in the summer because a lot of them get that, what we call the swimmer's ear, but then it can turn into that otitis media. A lot of them are also accompanied with respiratory infections. It's very common that we see them in pediatric clients less than 2 years old. So it can occur at any age, but again, it is most common in children and less than 24 months old. Lots of times, 80 to 90% of these pediatric patients have one prior to going to school. So you see how um, the incidences increase the older they get. It begins as an inflammatory process, typically following that viral upper respiratory infection. And then it involves the mucus of the nose, the ear. All of it is all connected. I kind of think about the head. It's all entryways for infection. The eustachian tube is the smallest part of that opening, and you can see it. It's right near that tympanic membrane. And the area, the microorganisms or the organisms tend to colonize there and accumulate, and that's what's causing the pain. Sometimes it can cause serious buildup of fluid and purulent drainage, or just some clear or amber colored drainage. A lot of times we'll see in some patients. There's 3 degrees. It could be acute otitis media. It could be chronic suppurative otitis media, or otitis media with effusion. And that effusion indicates that fluid buildup. The most common, it could be viral, bacterial, or a combination. The most common viral are your RSV. So think about the age of the children that get RSV. They're usually younger and under 2 years old. Could be caused by a coronavirus, an influenza virus, or an adenovirus, which is also encompasses the adenoids, which tend to grow larger in kids who have a lot of ear infections. The bacterial organisms are most often your streptococcal pneumonia, and then your Haemophilus influenza. So the etiology, um, like what places these patients at risk or why does it occur? The decreased immunity could be due to the HIV virus, it could be to childhood diabetes or other immunodeficiencies. There could be a genetic predisposition. My oldest son had terrible ear problems his whole life. I think he had about 12 sets of tubes. And even at the age of 12, he had a permanent set of tubes in. I think it's caused some hearing loss, although he says it doesn't. Now he's 28, but he talks kind of loud. And we noticed as he was, as he was aging, he would turn the TV louder and louder. And I'd be telling him, turn the TV down, turn the TV down. Or he'd be in the back of the van and he couldn't hear the radio and he'd want to hear the radio. So that was always a sign that I needed to take him to the doctor. Sure enough, he always had an ear infection. Um, Mucins that could include abnormalities of the gene. A lot of times, some of our syndromes, like our Down syndrome and some of our other syndromes, a ciliary dysfunction where the ciliary is not able to get rid of those organisms. And then cochlear implants sometimes, a vitamin A deficiency, viral or bacterial pathogens, and then just those chronic allergies. Living in Georgia, we see a lot of kids with allergies and otitis media that accompanies it because everything's going to drain. Remember, it's all connected. Sometimes lack of breastfeeding, passive smoke exposure, daycare attendance. Kids stick everything in their ears, their nose, their mouth, wherever. Low socioeconomic status, and then a family history of recurrent acute otitis media in those parents or siblings. So, what are some of the clinical features? They come in looking just like this poor little baby. Their earache, it could be mild, it could be severe, they could be fussy. They lots of times they're pulling at the ear because they're trying to make it feel better. They have trouble sleeping. Like I said, we see a lot of kids in the middle of the night because the earaches wake them up. They may or may not have a fever, but it could be there. They may or may not have any yellow, clear, thick, bloody drainage. Sometimes a loss of appetite, especially if they're still bottle fed, because when they're sucking on the bottle, that really causes the ear to hurt even more. They could have some vomiting. They're most often irritable and grumpy. So, how do we differentiate if it's an ear infection? Because some 2-year olds are always irritable and grumpy, right? So, it's just kind of looking at your symptoms and then getting them checked out. Symptoms of that fluid buildup in the ear. Again, these patients have trouble hearing. My son's would always start to drain, but he would start to lose the hearing and have not necessarily pain, but he would start to have symptoms before that fluid buildup. Sometimes they'd get popping sensations in his ears, fullness or pressure. And again, that hurts. And they think about the age group, they're not able to tell us exactly what's going on, right? Could be rubbing the ears, and like I said, difficulty describing what is wrong. They can't describe it. They could be inattentive, and then cranky, dizziness, sometimes balance issues. Because remember, our inner ear, if there's issues with the inner ear, we could have vertigo and problems balancing as well. So, how do you think we diagnose this? Anybody have any idea? Nobody? Anybody taking care of somebody who's had an ear infection? Or have you had an ear infection?
It was that the child is keep pulling the ear. They keep pulling the ear.
Yep, pull in the ear and then visualization. Us as nurses, sometimes you're going to visualize and you can see that that patient is the ear is really, really red. It might even extend out to where we can visualize it just looking in as well. So a lot of times it's symptomatology, pulling at the ear, the fever, the accompanied things that go along with it. There's no real one test that says, oh, they have an ear infection because they have a positive blood test or whatever. Sometimes they might culture the ear. A lot of times it's a physical exam. They use the otoscope to take a look and visualize. If it's really severe, they may do a hearing test. The tympanometry is going to measure how the eardrum responds to the change of air pressure inside the ear. A tympanocentesis is it's going to test and remove that fluid that's in the ear. And then serum blood tests might be done to test the immune issues if it's an allergic or thought to be called caused from some type of allergy or autoimmune disorder. But most often, they're not going to do serum blood tests for immune issues unless it's chronic and more recurring. So that's probably going to be done in a doctor's office and not necessarily in the hospital. What's our treatment? Again, we're going to treat those symptoms. We might give them some ibuprofen. We might give them some Tylenol. Antibiotics for children if they're less than 6 months old, for sure. Because again, remember, our vulnerable populations are very young and are very old. Warm compresses might help to the ear. Rest. Surgery to put those myringotomy or those tympanostomy tubes in, and then also taking out the adenoids might help. A lot of times, these patients are treated at home, especially if it's viral. Remember, there's no real antibiotics to treat viruses. So, definitely need to do good follow up exams and then maybe keep a track of how often the patient has those ear infections or the repeat ear infections. So your myringotomy tubes, they look just like a spool of thread, but they're very, very tiny. You see, it's 1.5 millimeters, so you don't even know they're in there. They typically will fall out themselves, and you may not even know that they've fallen out. It's not like you can see them come out all the time. They place a small incision in the eardrum so it drains that fluid to release the pressure of that middle ear. Your PE tubes are your pressure equalizing tubes, and they're going to ventilate the ear and prevent that further fluid accumulation. What happens is then that eardrum is going to heal around the tube, and these patients have that opening that helps that fluid drain. They typically last about 6 to 12 months, hence why my son had to keep getting them because they don't last very long. So, can you say cha-ching, cha-ching with all the surgeries he had to have? And then if they're permanent, they may be removed by the physician. Again, the older they are, the more permanent they're going to be or long term. But then they may have to be removed by a physician or a surgical procedure. What's our post op care? They should not have a lot of bleeding. They may have some light yellow fluid from the ear, a small amount of bleeding, possibly, but we really should not see any excessive bleeding. So, if we do, or we see that purulent drainage, it's definitely something to be concerned about, and we have to contact the physician. Educate on eardrop installation. Sometimes, well, most often they'll come home with cotton balls that can be removed later after surgery in the afternoon, or a couple hours after, or they just fall out. We want to educate these patients to blow their nose gently and then sneeze with their mouth open, because think about what happens if we sneeze with our mouth closed. That builds up pressure in our head. Want to tell them to elevate the head at least on 2 pillows when they're sleeping. And then this is the most important, especially in the summer. A lot of times parents will want to wait till the summertime to have the child have surgery because they're out of school, right? Well, what do they want to do? They want to go swimming. So they cannot have any water to their ears for about 10 days. And they're probably going to come home with some type of eardrops as well. Definitely educate on using those earplugs when swimming or washing their hair. Oh, that didn't pick up on that typo there. Sorry about that. And then acetaminophen or ibuprofen for pain, anything over the counter. They typically do not send them home with um, any narcotic pain medicine. They really don't need that most often. So, some complications, these patients may get abscesses. Obviously, your intracranial is going to be worse than your post-auricular. But again, an abscess is an infection, so we don't want anything. Sometimes they might get some facial nerve paresthesis or paralysis. And then labyrinthitis, which is that dizziness and vertigo. They might get some temporal abscess as well, or it could lead to meningitis. I used in the early mid 90s, I used to work in an outpatient surgery center. And on Thursdays and Fridays, our pediatric ENT doctors would just put tubes in after tubes after tubes. Never saw any complications from it. The worst complication I saw is that the patients had to come back and have them reinserted for whatever reason. Sometimes they might get some odic hydrocephalus, where they get fluid buildup that is right behind the the ear, and or sigmoid sinus thrombosis, which could be kind of dangerous because again, a thrombosis is a clot. So we definitely want to monitor these patients. Those are some of the worst complications. And again, they're very rare. Any questions on otitis media? I'm dealing with this right now with my daughter. I feel for you. How old is she?
She's two
Whoa.
now, but she got the tubes. We got tubes when she was
briefly a little bit after 1 years old, but every time like she gets sick or get a respiratory like infection, her tubes tend to bag up. So the fluid
Yep.
from her, the mucus and stuff, it bags up in her tube. And now, since it's something that's been chronically happening all the time, now we're going to be scheduling surgery to get her adenoids taken out.
Yep.
So
Yep.
that's where we added tube replacement. So
Yep. Sometimes they might put wicks in the ear as well because the fluid keeps building up. My older son had his adenoids removed too, but he still suffers. And anytime he gets sick, he still gets it. He's 28 years old, and they were here last July. He lives in DC area, and he flies frequently, but they were here for my daughter-in-law's shower, and his ear started draining, and he was getting ready to fly, and I'm like, no dude, you need to go have it looked at because you don't want to get on the plane, because what happens with the pressure? And he's 28 years old, so the pressure from the plane can burst his eardrum. Is it life threatening? No. Is it uncomfortable? Yes. So I'm like, well, you may just have to stay with your mama for another day. Poor child, right? But he was fine. He got some treatment and he was good. But that, unfortunately, the younger they start, he had his first set of tubes before he was a year old. So the younger they start, the more chronic it is, unfortunately. But I would take that over some of the worst complications that there could be, or illnesses for children, right? So we choose our battles. So the next disorder we're going to talk about is tonsillitis. And tonsillitis is the inflammation of those two oval shaped pads at the back of the throat, which are our tonsils. So you can see a picture between the normal tonsil and the inflamed tonsils. Sometimes these patients get so bad that it can obstruct their airway. And we call those touching tonsils or kissing tonsils, where they have such a minimal air space in the back of their throat because their tonsils are so inflamed. Could be caused by a virus or it could be bacterial. And again, to think about it, they're all in the same area: the rhinovirus, respiratory syncytial virus, the adenovirus, and then the coronavirus as well. The bacteria is typically going to be in a strep nature. Most often, it's A beta or beta A streptococcus. Does require treatment and it can be very painful. The inflammatory process of that tonsillar tissue is what causes the pain, the difficulty swallowing, the fever, the infection. Um, Again, it can start with just a sore throat and then become much worse. The older the patients are that they remove their tonsils, the more difficult or painful it is for the patients, unfortunately. Pathophysiology of that tonsillectomy, that inflammation, of the tonsils that's caused by a virus, results in the formation of exudate. Typically, that purulent drainage um, becomes like cellulitis of just those tonsils, and that's going to occur in the surrounding area of the mouth as well. Sometimes these patients can get peritonsillar abscess formations, where they get a formation on top of those, an abscess form on top of those swollen tonsils. So, what do we really need to think about with these patients to protect them, especially in children? What do you think we need to monitor and make sure is safe? Anybody? Nobody wants to talk to me tonight? How about their airway? Anybody be concerned about their airway? They got an abscess and then they have swollen tonsils. That can be very serious, right? And especially with kids, remember their airway is much smaller, right? They have a much smaller. Theirs is the size of a straw, where ours is not much bigger, but it is bigger. Oh, there's somebody put airway. Thank you. So, and then it can lead to tissue necrosis. If recurrent treatments, they'll typically suggest a tonsillectomy if they have more than 2 or 3 episodes of tonsillitis in a 12-month period. And even sometimes at that, that's a little much. It depends on how severe it is as well. So getting a good ear, nose, and throat doctor would probably be good. So, what are the signs and symptoms of tonsillitis? Again, they're going to have a fever. They're going to be sick. Tonsillar exudate, sore throat. They may have some cervical lymphadenopathy. They may have dysphagia. When we go to do that physical exam, we're going to visualize those enlarged tonsils. They're going to be very red, inflamed, and might even have limited visualization of that posterior oral pharynx due to that swelling, and then it would be those kissing tonsils or touching tonsils, like we call them. Can be very severe. So we need to definitely maintain the airway on these patients and get that infection under control. So how do we diagnose it? Basically, it's going to be that direct visualization and looking at them. We might palpate those cervical lymph nodes to see that they are swollen. Palpating the spleen. Why are we going to palpate the spleen? And what are we going to see? Does anybody know?
There might be splenomegaly.
Splenomegaly, yep. And remember, our spleen helps us fight infection. So if the patient already has an infection, and then now they've got a worse infection, it might enlarge that spleen as well. Rapid strep screen we typically will perform to make sure it's not strep. On top of that, tonsillitis as well. So they'll do a throat swab. Again, we're very cautious with our throat swabs because we don't want to go sticking stuff in the back of their throat to irritate it more, to make it more swollen. Sometimes they might do a CBC just to test the white count to see if it's elevated, and then to look at the difference between that viral or bacterial in the blood cells in the differential of that CBC. They might and they can definitely identify the organism once they do a throat swab. So, is it under the nurse's role? Can a nurse take a throat swab, a strep screen? Is it within the nurse's scope of practice?
Yeah.
Yeah, it depends on where you work, especially in the emergency room. The nurse can do it. It is under your scope of practice. So for treatment, it's going to be rest, adequate fluids, warm fluids. We don't want to give them anything really cold to shock them because that could also irritate it more. Tea or warm water with honey is very soothing. Saltwater gargles help. And then humidifying that air so that it's not so dry through the airways. Because if you think about it, if they have swollen tonsils, they're probably sleeping with their mouth open, and that's going to dry out. Avoid cigarette smoke. Again, cigarette smoking is bad, but we can't always get families to stop smoking. Acetaminophen for pain, antibiotics. Excuse me. And then a tonsillectomy. So, what do y'all know about a tonsillectomy? What's our biggest concern with a tonsillectomy? I'm sorry?
It's painful and bleeding.
Bleeding.
Airway, breathing,
Airway.
Yep.
dysphagia.
Yep. the biggest complication post tonsillectomy is bleeding. And it typically, if it doesn't occur immediately, it typically occurs 10 to 14 days after they've had the procedure. So that's the time period we really want to watch these patients and educate the family, because that could, if you've ever seen somebody who's had a tonsillectomy and then bleed 14 days later, it's a good significant amount of blood, and it can be scary for the parents as well. So our nursing interventions are going to focus around that bleeding, assessing that airway very frequently, because again, we've manipulated, anytime somebody goes to surgery, they're going to have swelling. So we're doing surgery on the tonsils that could still cause swelling. So we definitely want to assess that airway. Don't want to be sticking a tongue depressor down their throat, but we do want to visualize. And another way to watch is to make sure that they don't have drooling. If they're drooling, they can't hold their own secretions. Monitor their vital signs. That's going to help us indicate any infection or any worsening infection. Monitor for their fever, provide rest, and then cool liquids post tonsillectomy, and then provide emotional support. Again, when we're taking care of children, we're not just taking care of the patient, we're taking care of the mom and dad too. Does anybody work in pediatric area? Parent education, absolutely. So somebody asked, so why frequent swallowing an issue? So you think about it, if they're swallowing frequently and they're bleeding, they're trying to get rid of that blood, and that could be an irritant. So we really need to monitor that. If they were fine and now all of a sudden they're swallowing, blood doesn't taste good, and they're not typically going to spit it out. So just monitoring that and making sure that it's not bleeding. It's not necessarily saying it's an issue. It's saying that's something we need to watch for and to assess, because it could become an issue of bleeding. Provide emotional support. Absolutely. Absolutely. Any questions on tonsillitis and the nurse's role with tonsillectomy or any of those? Everybody's good? Okay. Let's talk about conjunctivitis. It is an inflammation of that transparent membrane that lines the eyelid and the eyeball, and these poor babies look just like that. The membrane itself is called the conjunctiva. The conjunctivitis is also frequently known as pink eye. We know it's very contagious, and we know that what can help prevent the spread of it. If we're educating mom and dad on sending a baby home with conjunctivitis, what are we going to tell them to do frequently?
Wash their hands.
Wash their hands. Yep. Especially if they're doing eye drops. You want to make sure they're washing their hands before and after using the eye drops. It's most often viral. Sometimes it can be bacterial. They can also have allergic conjunctivitis. In babies, it is typically due to an unopened tear duct. So sometimes going in and probing those tear ducts will help the the frequent and the allergic conjunctivitis go away. It does not cause any visual changes, although they may think it does because of the gunk in their eye. They can't really see, but it does not cause any structural visual changes. It can be uncomfortable. And then early diagnosis is key. Why is that key? Why is it key to diagnose it early?
It might be contagious.
Yes, to prevent the spread. Absolutely. So, what are some of the things we're going to educate parents on that we also want to help prevent the spread of it? What are some other things? Good hand washing, we said. Don't touch the eyes. Absolutely.
And do not send your children to school without
Yep.
starting the antibiotics.
Yep. Do not send the kids to school without being on the antibiotics for at least 24 hours and the drainage somewhat stopping. Contact precautions. Yep. What
Avoid
about,
touching the ear.
ma'am?
Avoid touching the ear.
Yes, avoid touching it. Absolutely. So, what about their clothes and washcloths?
Wash
What do
them
we need?
separately.
Wash them separately in hot water. Yep. It should be hot water and not just warm. That way, because remember, hot water is going to kill the infection, especially if we're talking about with detergent. So, signs and symptoms, they're going to have pink or red. Sometimes it could be white if it's the drainage and if it's purulent. I've seen some really disgusting looking drainage in some people's eyes. They may have swelling to the eyelids, crusting in the eyelids. Baby shampoo, Johnson's baby shampoo will really help, and you can put it in the eyes. It's very it's not caustic to the eyes, which is why it's baby shampoo, right? Um, their eyes might be watery and teary. The discharge could be pussy, mucusy, or it may be clear, white, yellow, green. It could be anything depending on the organism. The eyes are going to be itching, burning, and red. And then they're feeling like something's in their eye. So they constantly have that urge to rub it, especially kids, because they don't know any different. So they rub their eyes, and what do? They go touch everything, right? So, really, the spread of it is what we really want to try and contain so nobody else in the house gets it. So I put a little chart in here with the different types and what the symptoms are going to be. Your viral is typically going to be watery and not thick. It might often be clear. And these patients are typically going to have a cold or the flu or an upper respiratory infection. It usually begins in one eye and it can spread to the other eye within a couple of days. Your bacterial is going to be more of a thick pus-like thing, and the eyelashes and the eyelids can stick together, kind of like the first picture of the baby. That one typically occurs with an ear infection. We see a combination a lot of times. You're allergic and your conjunctivitis caused by irritants are not contagious. So think about the organism or what causes it. Why would it not be contagious? Because it's not infectious, right? Patients who get chemicals in their eye can get a chemical conjunctivitis. That would be the irritant. Sometimes smoke. People who are out building doing a lot of fire and burning can get conjunctivitis from the smoke and the ashes. Those tend to be watery eyes, and mucus discharge may or may not be there. Your allergic is going to be in both eyes. Um, Teary, swollen, red, lot of itching, and then they're accompanied with other allergy symptoms, typically itching, nose drainage, sneezing, scratchy throat, and then you can have some of your asthma symptoms as well. We diagnose it sometimes. Most often, we diagnose it by visualization. But if it's severe and recurrent, they might do some eyelid cultures and cytology, which is they send it to the lab and test it in the cytology to see what the organism is. They may do a gram stain where they take kind of like what they use for it's just a swab, but it goes into a tube. It's a special, and then they'll gram stain it in the lab if they think it's bacterial. They might do some superficial scrapings if they're trying to diagnose that allergic conjunctivitis. Eyes are one thing that kind of like, oh, I don't like eyes. Anything to do with the eyes. They may flush out the eyes, especially if it's allergic. We've put in Morgan lenses in the emergency room and they're really irritating. We've put in Morgan lens and flushed out the eyes for allergic and that chemical as well. Your treatment is first off is going to be decrease that spread of infection. We might use eye drops or eye ointments. The eye ointments tend to work a little better, but they tend to also make the eyelids stick together, and patients don't. They tend to be a little less compliant with the ointment, and the ointment can cloud or irritate their vision, make it a little worse. Anytime somebody who has contact lenses, they're going to get a fluoroquinolone, such as Levaquin or one of those medications. The others might be polymyxin or Bactrim or ciprofloxacin eye drops. So your complications, eye pain, light sensitivity, blurred vision, could have some intense eye redness. And then because of all the scratching and the itching, they may develop some corneal abrasions or injuries to the corneal. So trying to tell them and keep them to, or trying to teach them to keep their hands out of their eyes is key, but it could be very difficult. Any questions on any of those? Can they do warm compresses maybe on the eyes? Yes. Yes. My eyes tend to water very frequently. I've been to so many ophthalmologists. They're much better now, but my daughter my daughter for Christmas bought me this it's an eye massager, and it's warm, and it plays music, and it tells you to close your eyes, and it literally massages your eyelids, and um, also has warmth to it. So I'm like, ooh, that was a really good gift she gave me. They are going to be red, yes. What else do we want to teach these patients after they've been on that antibiotic? We want to make sure that they wash their sheets. If they're females or even if they're males and they wear makeup on their eyes, they need to throw away that makeup and get new makeup. So, our kids are starting younger and younger wearing makeup and some stuff. So, we definitely need to tell them that. If they're wearing contact lenses, they need to take the contact lenses out, throw them away, and do not put them back in because they're going to reinfect themselves. They probably need to stay wearing glasses while they have the active infection. Bed linens need to be washed separately. I would say pretty much every day you need to wash it, especially the pillows, because you don't know what's draining at night. Any questions on any of those so far? All right, let's talk about strabismus. Does anybody know what strabismus is? No? That's an honest answer. So let's talk about what it is. It is a visual problem where the eyes, one eye, or actually one or both of them are not aligned properly, and they can change, they can switch. One may go straight and the other may go awkward or turn inward, and then it may be the other eye the next day or next hour, whatever. They're going to point in different directions. We see it associated a lot with some of our syndromes, especially our Down syndrome babies. And the other name for it is cross-eyed. Is it dangerous for these patients? Can it cause harm to them?
I don't think so.
Yeah, it doesn't necessarily cause harm or be dangerous to them. It can be annoying, and the danger could occur if they can't really see or they have trouble walking. You know, these patients could fall, especially for kids that are younger and they're just starting to learn to walk. So, some of the risk factors are your Down syndrome babies or your patients with cerebral palsy. I had to look this one up, the Apert-Cruzon syndrome. I had never heard of that. It's a form of acrocephalodactyly where these children have the large heads, large hands. It is a congenital disorder. And it's a malformation of the head, the face, the hands, and the feet. We see it a lot in premature infants with low birth weight, and then it can be hereditary. It can take on several different forms. It could be mild to very severe. You see in some of your Down syndrome babies as they age, it becomes more severe. There are some things and treatments, and we'll talk about those in a minute. Exercises that they can do on the eyes to try and correct it or get it a little bit, I guess, straighter, for lack of a better word. We diagnose it by visual acuity, by visualizing it, and then having them read the Snellen chart. We can also evaluate refractive error, and that's done with a test. And that's a particular test done at the ophthalmologist office. Um, some of the treatments are those orthoptic exercises, and they're particular exercises, like I said, to try and straighten out the eyes. Prismatic correction, again, has to do with the prisms in the eye, and they'll change or tell them to cover an eye. Sometimes some miotic drops will help, and then Botox injections. And then often, and if it's very severe and very troublesome, they'll do extraocular muscle surgery. Some complications, again, it's not life threatening, but they can have some complications. They can have diplopia, that double vision, nystagmus. They can have an abnormal head and neck posture because they're always trying to focus in and look. They may have some impaired social and mental growth. And, you know, you think about that could be a complication as these kids age, they could be picked on. And, you know, it's not nowadays, the things that people get picked on and the things that occur because of it are not good. So really trying to help them and just foster acceptance, right? Some complications of the surgery, if they should have that strabismus surgery, again, is that diplopia. They can under or overcorrect on the one eye that is bad. They can have some conjunctival scarring, some granulomas, or they can wind up with some chronic inflammation of the area. Scleral perforation, which would not be good. Lost muscle in the area, anterior segment ischemia, or a retrobulbar hemorrhage, which again would not be good. And that again is your retrobulbar area is behind the eye, and you got bleeding behind the eye, which is going to cause pressure, which could cause loss of sight if it's pushing on the optic nerve. So, you know, a lot of times these patients don't have the surgery, or the parents don't let them have the surgery because of the complications. Any questions on any of that? All right. let's talk about allergic rhinitis. So it is an atopic disease that presents with symptoms, and we all know sneezing, nasal congestion. They could have some clear rhinorrhea, nasal pruritus, itching. It is an IgE mediated immune response, so sometimes allergy testing can help with that. And then leukotriene involvement. Our leukotrienes, and we kind of talked about these if you were on our respiratory pharmacy lecture. Leukotrienes are, I guess, antigens in our body, or antibodies, I'm sorry, that go to the site of an infection and they cause swelling. That's what they normally do. But in the case of anything or any disease where we have swelling, such as in asthma and such as in allergic rhinitis, you got swelling in the nares, you don't want those leukotrienes to then increase the swelling. So oftentimes some treatment of that, or for allergic rhinitis, is going to be those leukotriene inhibitors. Just like leukotriene inhibitors are a treatment for asthma. So if you know what the involvement is and that they go to the site of the irritation or the injury and they cause swelling normally, we want to inhibit that swelling by giving the medication. It involves the nasal airways. It can be deep in the nasal septum, or it could be superficial, or it's not really superficial, but right at the entrance of the nares. There's different stages and how they classify it, where patients can have early and late phase reactions, which means it could be later on. I have allergic rhinitis, and I'm sure you all have picked up on that. It depends on what's going on. My house that I live in developed mold from a roof leak. So, therefore, it's caused my asthma and everything to go crazy. And we had to move out of the house for 4 weeks. So, I'm in a new place for 4 weeks. So mine is an early or a late phase. It depends on the time of day and how much of the irritant is there. Initial response could be 5 to 10 minutes to that exposure. So sometimes I can walk in the house because I've been dealing with this for several months, fighting with insurance. And I would be fine, but all of a sudden, 2 hours later, I'd have that late phase reaction. Or sometimes I could walk in within 5 to 10 minutes, and it's causing that initial response. So just know that these patients, and it might be hard to identify what the causative agent is because of that late and early phase. Sometimes for some people it's food. Sometimes it's just irritants. So a lot of times skin testing and allergy testing is what helps them identify it. Signs and symptoms and diagnosis. Again, a good history and physical. Identify any family history of it. Do they have a lot of mouth breathing, sniffling, frequent throat clearing, nasal crease? That's when you look at their nose and you'll see a lot of nasal creasing, and then dark circles under their eyes. So now you got to identify if it's an adult, are they having dark circles under their eyes because of lack of sleep or because of allergic rhinitis? When we talk about kids, kids typically don't get dark circles, right? So it's a lot easier to often identify it with kids. We diagnose it. They can do a rhinoscopy where they actually put a scope up the nose. They'll kind of numb it and put some numbing spray and put a scope up the nose to take a look. Um, a new a pneumatic otoscopy. Again, it's another kind of tube where they can suction through it if they need to. Palpating the sinuses. Y'all know where your sinuses are. Are they tender? Do they hurt? Do these patients scream in pain? And then assess for any code disease processes. We see it oftentimes with allergic rhinitis, a lot of our asthma and allergy like code diseases. Asthma, we see some of our autoimmune disorders as well. And then assess for aspirin sensitivity or allergy. There is a process called Samter's triad where these patients develop nasal polyps from the allergic rhinitis or in conjunction with the allergic rhinitis, and asthma and an aspirin sensitivity. And it's called Samter's, SAMPTERS triad. So it's the three things: the aspirin sensitivity, nasal polyps, allergic rhinitis, and asthma. Well, the nasal polyps and the allergic rhinitis kind of go together, and the asthma. Treatment, definitely going to avoid those triggers. Wash their sheets in hot water because, again, we don't know if they're draining at night. Use HEPA filters in the air conditioning vents and in the vacuum cleaners. Medications, your leukotriene inhibitors, your antihistamines. But remember, your antihistamines can make patients sleepy. So, depending on what type of work they do. Nasal sprays, and then, like we talked about, the leukotriene inhibitors. Educating somebody on the proper steps of nasal spray, they're going to place the tip of the bottle inside the nair, and they're going to aim laterally towards the ipsilateral eye. So kind of up and out a little, and then spray, and then monitor for the side effects. So depending on what the type of medication is that's going through the nasal spray, these patients may complain of some burning, some irritation. They may feel like they need to sneeze. But we're trying to keep that medication in. And you want to tell them to hold the nair. They're not putting it in. You want to close off that nair. And then go to the other side. Some complication, they can have some chronic rhinosinusitis, bad sinus infections, and sinus infections can make people feel really sick. They can develop nasal polyps, and I got a picture there. That's what a nasal polyp looks like if you're visualizing it. Allergen desensitization with that allergy testing, and then receiving allergy shots once they identify it. Sinus surgery to remove those polyps. The only thing with that is there's no guarantee that they won't grow back if you're not treating what the cause is or identifying what the cause is. Any questions? Montelukast, yes, that is one of your leukotriene inhibitors. The other name for that is Singulair. And then it's also Zacurfilast, which is Accolate. Your Montelukast is once a day dosing, typically at night for children, and they do make it chewable. And then your Accolate is twice a day. Any questions on any of that? Any comments? You guys are quiet tonight. So let's talk about epistaxis, nosebleeds. What are they caused for, or what are they caused from? Broken blood vessels in the nose that tend to bleed. Typically occurs in the front part of the nose, especially in children. They typically don't have those deep septal bleedings like adults get. Adults tend to get it most often due to their anticoagulants. Kids typically get it. Do you know why the most common cause of or reason for a nosebleed in a child is? Sticking their fingers up their nose. They typically tend to start doing that. Overheating. It's not so much overheating, but like in the winter time when the heat is really dry, that can cause it as well. But children typically will start finding their orifices about age 2 or 3. So their fingers are constantly in their nose. It is very common in children. Some of the causes is dry air, picking their nose, blowing their nose too hard, or then injury or trauma to the nose. They're playing baseball, they're getting hit in the nose. Colds or allergies can cause it if they're severely stuffed up or having a hard time breathing because of their sinuses being so stuffed. And they put objects in their nose. So many times we've seen kids in the ER because they put vitamins, toys, Legos up their nose or in their ear. So to retrieve them, they're called alligator clips, or alligator forceps. They look like scissors, but they have very long, little, I guess, like scissor part. And at the very end, they have these very little, grabbers, and the doctors go in and grab it and pull it out. Risk factors could be your geographic dry climate, so the desert, heat in the winter, like we talked about, environmental allergies and irritants can cause it. And then too much nasal spray can also cause an irritation and cause nose bleeding. And then frequent colds. Your signs and symptoms and your diagnosis, obviously we're going to see that bleeding, right, coming from the nose. And remember, anything from the neck up bleeds pretty badly, so it could be pretty scary for these parents. It's typically painless bleeding and could be due to that trauma as well. Diagnose, we visualize, and then we evaluate or treat or further diagnose if there's any head trauma associated with that bleeding. So then we're going to go from there and then diagnose any further issues if we need to get a CAT scan. But again, if we identify any other traumas, that's what they're going to treat as well. Or I'm sorry, that's what they're going to diagnose or evaluate further. So, treatment, calm the patient and the client and the parent. Sit the patient upright and lean forward. We do not want to tell them to put their head between their knees because that's just going to cause more bleeding due to the pressure of going forward. Educate them to breathe out of their mouth so they can avoid aspirating the blood. Avoid the cold compresses to the bridge of the, apply cold compresses to the bridge of the nose because remember, cold vasoconstricts. Educate them not to pick their nose or blow it for at least a couple days post the episode. Doctors often may need to pack it or cauterize it. They may use some silver nitrate. We may pack it for adults. We actually use cocaine spray to stop the bleeding sometimes. Tranexamic is a medication that will stop the bleeding. Remove the foreign body if there's one in there. They might need ligation or they might need surgery if that nose is broken and that's what's causing the bleeding. How to avoid it? If it's due to the dry weather, they can use some saline nasal spray, use a humidifier, avoid that forceful blowing of the nose, and then sneeze with the mouth open, but make sure they cover it so that they're not spreading germs everywhere. And then avoid putting anything in the nose. Any questions? Are you ready to do some practice questions? So the more you read, the more things you will know. The more you learn, the more places you will go. And that's from Dr. Seuss. Does anybody have any questions? All right, let's go through some questions. So, a nurse is working with a new graduate nurse who is administering eardrops to a 2-year-old client with acute otitis media. The new graduate nurse should gently pull the pinna which way?
Downward and backward.
Yep. Good job. Do you know why? Because kids that are this child is 2 years old.
So the child is 2 years old. I'm sorry.
Yeah. I was gonna get to that. So children under 2 years old, or I'm sorry, under 3 years old, that ear canal is more horizontal and it's shorter because they're younger, right? They haven't grown. So we want to pull the ear out and backwards. For older, I'm sorry, downwards and backwards. For older than 3 years old, which way do we want to go?
Same way.
And back.
Same way.
Upwards and
No,
backwards.
up and back.
It's
Up and back because that ear canal tends to get larger and not be as horizontal. And then upwards and forwards or downwards or forwards, they're not appropriate for any type of eardrops. If we go up and forward, that's going to fall out and it's going to actually occlude the ear. And the same thing with downward or forward, it's going to occlude that area and the eardrops aren't going to go in. They're just going to fall out, right? Does everybody see that? Any questions? Okay. A nurse is reviewing the laboratory tests of a child scheduled for a tonsillectomy. Which of the following findings should the nurse notify the provider immediately? So this is a priority question. So which one? And you could be notifying the provider on all of them, but which one is the most important?
Protruding time.
PT time. Yeah, PT.
Yep. Why the PT time?
It's
Risk of
Because of bleeding.
bleeding because
Yep.
yeah.
Yep. Because tonsillectomies cause a lot of bleeding, right?
Yeah.
So it's already his PT time is already longer, it's elevated, which means he could have some coagulation issues, right? So if we were saying he was scheduled for myringotomy tubes, which would be the correct answer? Which one would we need to notify the provider immediately on?
The white blood cell count.
The white blood cell count.
That's
Yep.
infection. Yeah.
Yeah.
It goes for infection.
Yeah, because it's infection, right? They may still do the surgery depending on what's causing it. We would also take into consideration the PT time, but there's not a lot of blood loss with putting in myringotomy tubes, right? So they may still not do it because of that.
Again?
Ma'am?
Could you please
She said,
repeat
can you repeat the
again?
question? Why we chose white blood counts?
So I was just changing the question and giving you another example of how to apply what you know. So this we know tonsillectomy causes a lot of bleeding, right? So we would be more concerned if the PT time is elevated because that patient would be more prone to bleeding. So I turned the question around and said, what if the surgery was myringotomy tubes, putting tubes in the ear? Which lab work would we be most concerned about? And the students said the white blood cell count, which is correct because putting in myringotomy tubes does not cause a lot of bleeding. The physician may still choose not to do the surgery, but bleeding's not related to those myringotomy tubes. Infection is more related to that. I was just pointing out how reading the question and applying what the content is helpful. Does that make sense? A nurse is caring for a toddler 1 hour post tonsillectomy who is vomiting bright red blood. Which of the following actions should the nurse perform first?
Sideline position.
That's
Sideline
correct.
position.
Why are
First,
we
not to
gonna?
not
Why
to
are we gonna?
aspirate.
Yep.
To prevent aspiration.
You're still denying
To
it.
prevent aspiration.
Surely.
Absolutely.
No.
Absolutely. So remember, with our priority questions, all the answer choices could be correct because we may do all of those. But the first thing and most important that we're going to do is place them on the sideline. And then if this was a question that said put it in the order of what you would do, what would you do next?
I would sideline position, assess the pulse rate, notify the provider, and then give antiemetic aspirin.
Yep.
Prescribed.
Yes, whoever said place the child in a sideline position, assess the child's pulse rate, notify the provider, and then administer an antiemetic. Absolutely, because those are all priority, right? We place them on the side to protect the patient from aspiration. We have to assess what else is going on, and we definitely have to call the doctor too, and then we can give them the medication. If we do all of those, that vomiting and that bleeding may stop, but we need to protect their airway, right? Makes sense? Any questions?
No, Prof.
No.
Okay. A nurse is working in a new a nurse is working with a new graduate nurse in caring for a toddler 4 hours post tonsillectomy. Which of the following actions by the new graduate require intervention? Select all that apply. So again, this is select all that apply. So there's more than one correct answer choice. But we're looking for what? Are we looking for
wrong answer.
Answer.
an
Wrong
incorrect answer?
answers.
Yeah.
B,
So
D, E.
B, D, and E?
Yes.
Yes.
B, D.
Not A, B, D, and E. So prone is what?
On the back. On the belly.
Face.
On the belly.
On the belly.
Yeah.
He's on the stomach.
Yeah, that's okay. There's nothing wrong with that. What about encourages the child to cough frequently? We don't want them coughing, right?
That's wrong. That's
No
wrong.
pressure.
Yep.
No cough.
Yep. Offers the child crushed ice. They can have that, right?
Yes.
They can have cool fluids. Yep. Encourages the child to drink through a straw. Why do we not want them to drink through a straw?
To avoid
They
choke
can
air.
aspirate through
They
that.
can easily aspirate.
Well, they can aspirate if they're sucking on ice too.
To
But
avoid
what
Does it irritate the tonsils?
to put air.
well, the straw has to the key word there is a straw. So we don't want them drinking through a straw
Can lead to
because
the bleeding.
By swallowing.
you're getting there, you're close, you're good. It's
can
the
hurt.
Irritating the site and they can bleed.
that is true, but it can the more thing is it takes pressure to suck on a straw, right?
Yes.
So that pressure can dislodge a clot and cause cause more bleeding.
Nerves.
Okay.
Yeah. And then performs 2 hourly oral and nasal suctioning. Why do we not want them to suction this patient?
to increase intracranial pressure.
Not
No, it may cause bleeding.
It will dislodge the clot that is forming and bleeding will occur.
Yes, suctioning can dislodge clots or it can also cause bleeding. So that's the reason why we don't want to cause or suction either way. If they're bleeding, we want them to spit the blood out. Again, of course, if it's causing an airway problem, then we're going to suction. But other than that, no. A nurse is assessing a 6-year-old client 4 hours post tonsillectomy. Which of the following findings require immediate intervention?
C.
Frequent swallowing.
Frequent swallowing.
Yeah, that frequent swallowing, because that's a sign that they're swallowing blood. What's
Blood,
going
yeah.
on that they keep swallowing, right? Those other answer choices, we expect them to have a sore throat
Yeah,
4 hours
expected
post-op,
findings. Yeah.
right? We expect them to be drowsy. I hope they're drowsy because if they're not drowsy, they're going to be irritable, right? And then
Yes.
they may have a low grade temperature. So those are all expected. A nurse is educating the caregiver of a child 6 hours post tonsillectomy on appropriate foods for the child. Which of the following foods are appropriate? Again, this is a select all that apply.
Mango juice.
A. Ice pops, mango juice, and watermelon.
Watermelon, yeah.
Yes.
ABE.
ABE is good.
AB.
Okay.
I say
So
AB because the red juices
The
can
red juice of the watermelon may also interfere with the bleeding. Okay.
yep. You whoever said A and B, you are correct.
Yeah,
The ice
beetroot
pops,
and
the mango juice is fine. The beet juice is red, and we can't tell if it's red or bleeding. So even when we're giving
yes.
them Jello, we educate them not to get red Jello, right? Because we can't tell if it's blood. The ice pops, we would tell them no red ice pops. Macaroni and cheese is warm and it's going to be a little harsh for them to eat 6 hours post-op because they should be on clear liquids for
Wait.
at least the first 24 hours. And then watermelon juice is red too. So we definitely don't want anything red. A school nurse is caring for a child whose nose is bleeding after being hit during soccer. Which of the following interventions should the nurse include in the plan of care? Again, it's a select all that apply.
C and D.
B and D?
And D. Yeah.
C and D.
No, B is there,
Special.
and
A lot of bleeding.
So let's talk about
it's
these.
cold. It's not
C.
A.
Okay, let's talk through them. We
It's not
don't want
A
to
'cause it's
apply
warm.
warm compresses because
Exactly.
we want vasoconstriction. So cold,
Mm-hmm.
we can put cold across the bridge of the nose, right?
Yeah, no
We want
tilting
that
back.
vasoconstriction. So A is not correct. Why do we not want the child, if we tell them to tilt their head backwards, that blood's just going to go back and it's going to
Straight
go in
down,
their
yeah.
throat and their stomach.
Mm-hmm.
So we don't want that. Remember, we
Exactly.
want them to sit forward.
It's forward. Sorry.
Yes. Apply continuous pressure to the nose for 10 to 15 minutes. Yes, we want them to do that. That is a correct answer. Encourage the child to breathe through their mouth.
Yes.
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 Right. And then insert cotton swabs gently into the nostrils. Can we do that?
No. No.
No.
Well, actually, we can.
yeah, we
Gently,
can. We can
yes,
do it.
because it's gonna cause a tamponade. It's gonna cause that bleeding to stop if you're holding it on the area. Sometimes that's what we actually do, but we put vasoconstrictive or epinephrine on it epinephrine or that cocaine, which causes vasoconstriction, the cocaine nasal spray. We put them on cotton swabs or cotton balls and gently put it in there. Sometimes we have to pack the nose with what we call them rhino rockets. They're
Yes.
big packing. They actually look like rockets and they go up in the nose. So the correct answer is C, D, and E.
CDNE. Okay. Good to know.
A nurse is educating a group of nurses on epistaxis. Which of the following should the nurse identify as the common causes of epistaxis in children? Select all that apply.
So
B, D, and
I
E.
know of BD and E.
B, D, and E.
A, B, C.
Yeah.
Yes.
Yep.
B, D, and E.
B, D, and E is correct.
All right.
So we said frequent nasal picking, blunt trauma, and then foreign bodies. They stick something up their nose. Chronic myeloid leukemia typically does not affect children. Versus it's the acute myeloid, or I'm sorry, the acute hyper I can't think of the word. Hyperblastic leukemia is the most common in children. And then hypertension typically does not occur in children, but rather older adults. So if we're talking about the adult patient, chronic myeloid leukemia and hypertension and blunt trauma would be your most common answer choices, right? So if we turn it around and say adult, because adults have hypertension, adults, we hope they're not picking their noses. And then we hope adults aren't sticking foreign bodies up their nose either, right? So if you change that question, now we make it where we bring in Maslow's hierarchy of needs and I'm sorry, not Maslow's hierarchy of needs, Erickson's developmental stages of what do we expect them to do at that age. Does that make sense? So
Yes.
you might see a question reversed. And what would be the most things that we need to educate on the causes of an adult? A nurse is assessing a 6-year-old child diagnosed with chlamydial conjunctivitis. Which of the following interventions should the nurse perform next? We've already assessed her. We've diagnosed her.
A.
A. A.
A. Yep. Why A?
Because it's
Chlamydia is
chlamydia is
sexually
STI.
transmitted
chlamydia,
infection.
sexually transmitted disease.
Yep. It's a sexually transmitted disease, and somebody's doing something they shouldn't be doing, right?
Mhm.
So, as nurses, are we mandatory reporters?
Yes.
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 Yes. Yep.
Yeah.
A nurse is educating the caregiver of a 12-year-old client with bacterial conjunctivitis. Which of the following caregiver statements indicate understanding? And again, it's a select all that apply.
A, B, and E. A, B, and E.
A, B, and E?
Yeah.
No.
Okay, let's talk about that. A is I will wash my hands with soap and water after helping the child with eye care. Absolutely good hand washing, right? That's correct. B, the child requires designated towels until full recovery. Absolutely. And then how are we going to wash them?
We
Hot water.
Wash with
Hot water.
hot water.
Hot water. Yep. Why is C incorrect?
Because it was not stated that the baby is on antibiotics.
Right, and then we don't want them to wear their usual contact lenses. We want them to get rid of them.
A new one.
Yeah.
Reinfection, yeah.
Listen, guys, let the professor explain, please. Thank you. Go ahead, sir.
You don't
Professor.
want them to wear their usual contact lenses. You want them to get rid of those and get a new pair or a new set of contact lenses, because those have been already infected and you're just going to reinfect. So it's A and B, and then D, the child should return to school once the purulent drainage has subsided. And E is incorrect. Why? How far away should we hold the dropper above the eye? It's 1 to 2 centimeters. Half a centimeter is way too close. That could risk touching the eye and then contaminating the medication. So, any questions on any of these? Please type your response. Well, I don't always like typed response because I kind of like the interaction, and I think that helps you guys. Anybody need any clarification on any of those questions?
Yes, I missed the question before that one.
Okay. This one?
Yes, what was the answer for that one?
The answer is A. Because it's a chlamydial conjunctivitis, and we should not have chlamydia in the eye. So that means somebody's been putting things where they shouldn't be, or touching, who knows? I don't even want to venture to guess on that one. But the key word was chlamydia, and it could be a form of sexual abuse.
Thank you.
Please, what's the answer for the next one?
This one?
Yes.
So the correct answers were A, B. I got to read the question again.
And D.
A, B, and D.
And D.
Yeah, I had to read the question again. We all good?
Yes, Professor.
Yes.
Okay. So let's do a case study. A nurse is caring for a 2-year-old female client in the pediatric clinic. Your nurse's notes at 8 a.m. say the client was brought in by the caregivers who reported a 3-day history of ear pulling and difficulty sleeping. The caregivers stated that the child has been more irritable and has a decreased appetite. The fever was reported over the last 24 hours and no recent cold or respiratory illness. So, looking at that case scenario, if this was me, I would kind of try and figure out, I would recognize my cues. So, what do we recognize? A 3-day history of ear pulling and difficulty sleeping, right? What else?
Fever.
Otitis media.
Otitis media.
Well, wait a minute. Y'all are jumping ahead. Take it systematically, right? What cues do you recognize that tell you it's otitis media? What other cues?
The pulling
Of the ears.
difficulty sleeping, fever.
Irritable and that decreased appetite and fever, right?
Yeah.
So here's your physical exam at 8 a.m. Anything stand out on the head, ears, nose, and throat?
The bulging. The red and bulging.
The left, red and bulging. What about the purulent drainage? That's not
Oh,
normal,
yes.
right?
Mm-hmm. Yeah.
All right. Anything stick out with the respiratory?
Respiratory is good.
Respiratory is fine, right?
Mm-hmm.
What about cardiovascular? Are we good there?
We're good.
Right now.
Yes.
Cardiovascular is good.
Cardiovascular is
Gastrointestinal
good.
is good
What
too.
about
Yeah.
GI? Is that good or
Good.
bad?
Good.
Bowel
Good.
sounds.
Good.
Is it good? The bowel
Yeah,
sounds.
Yeah, it's good.
yeah, the bowel sounds are normal, active.
Yes.
Normal.
How
Yeah.
about neuro? Anything to be concerned about?
Yeah,
Irritability.
Irritable. How about skin?
No,
It's
good.
good.
Skin is good.
How about extremities?
Good.
It's
No.
good.
Very good.
So all of the cues that we recognize with the complaints and then the assessment all point to what?
An ear infection.
Bacteria. Bacteria
Yep,
conjunctiva.
that otitis media, right?
Mm-hmm.
Bacteria, yeah.
So here's your temperature and your vital signs. What's concerning to you?
The
The heart rate is high.
temperature, heart rate,
Oh, the blood pressure is
respiratory.
high.
His temperature is a little elevated. His heart rate is a little elevated, right?
Mm-hmm.
The nurse reviews the client's record. What is the client's most likely diagnosis?
Otitis media.
Otitis media, yep. So when you're doing these, even though this one was a little, I don't know, I would say it's easy, really take it apart and learn to recognize those cues back in, because they may not all be that easy, right? Pick out from your case study, what cues do you recognize? What does this pertain to? And then try and identify what you think it is. Do the same thing, just what we did with the physical exam and then with the vital signs. Every bit of information that you get, try to identify and pick it out right then and there.
So
Okay.
what is the difference between the acute otitis media and the otitis media?
I was going to ask
The
that.
AB.
Well, it's actually acute otitis media.
Yeah.
Because
That's
it
what I
came
wanted
on,
to say.
yeah, it's actually acute otitis media.
It was supposed to be acute, yeah.
I was thinking
it's
about
acute
that
because
too.
it came on. It's a couple of days. Otitis media, is it's acute otitis media. So
Yeah, but
really,
like, how would I know the difference in case, I mean, they asking me for the B?
so what do you mean? Say again.
How would I know the difference? Like, I know about the A, but what if the answer must be B, the acute one? How would I know?
So otitis media is more doesn't typically have a fever, and it's more associated not with infection, but with it's also called swimmer's ear. So the history of the patient would be he was swimming all summer, he doesn't have a temperature, and he's got an ear infection. Or I'm sorry, an earache.
Okay.
And a lot of times you'll see drainage with the otitis media.
So in this case, is it acute or just otitis media?
It is acute because it's not
Okay.
swimmer's ear. It's related. Acute is related to an infection, and the otitis media. See, y'all got me not reading all the answer choices, and I just went with what you were saying.
Yeah, because they'd be talking
How
to
you
each
can
other.
do that? So you really need to read all the answer choices. That was a good catch, whoever caught that. It's late in the day and I just went along with you, right? Because otitis media, but really need to read those answer choices. Your acute otitis media is related to infection, typically has a fever. Your otitis media is typically does not have a fever, may have drainage or may not, and is more associated with water and swimming and that type of stuff in the ear. It's also called swimmer's ear. The caregivers are concerned and ask why their child has recurrent ear infections. Which of the following responses are accurate? And this is a select all that apply.
Daycare attendant.
What's that word?
I'm only
Eustachian?
sure of B and D.
Your
BC
eustachian tube is your ear canal.
Oh, okay.
I am thinking is B, D,
B.
and G.
Child does not have respiratory infection. Respiratory
B,
infection.
I would say
B,
B,
D,
D,
E, G.
E, and G.
Okay.
Pacifier use.
Yes. So B,
Yes.
D, E, and G are correct. So A is incorrect because their eustachian tubes or their ear canal, children under the age of 3 are typically more horizontal and they're not vertical. Daycare attendants can increase their risk of recurrent ear infections. Bottle feeding in the upright position, that's what we want. But if they're being bottle fed laying down or propping the bottle for that baby, you sit them in the bouncy chair or whatever and prop the bottle, that can lead to ear infections. Exposure to tobacco smoke, yes. Pacifier use, yes. It can increase their risk for it because of that sucking, that constant sucking on it. Female gender doesn't necessarily have anything to do with it. We see it in both males and females. It's more so the age and how young they are. Remember, we said we see it a lot. We see
So
acute.
let me see. So it's one water, one oil.
I'm sorry. We see acute otitis media in children younger. We see that otitis media, that swimmer's ear, in older children. And then acute otitis media is more prevalent if it's accompanied or is more prevalently accompanied with an upper respiratory infection. So the answer choices are B, D, E, and G. So here's your physician's orders. Administer IV ceftriaxone 600 milligrams every 24 hours. Administer PO aspirin 80 milligrams every 8 hours. Administer D5.5 at 48 mLs per hour. Warm compresses to the affected ear as needed. Encourage oral fluid intake. Monitor pain levels in response to medication. Blood samples for CBC, BUN, creatinine, and electrolytes. And prepare for myringotomy with tympanostomy tube placement. So the nurse reviews the healthcare provider's orders. The nurse should clarify the prescription of. This would be a drop down on NCLEX. So your answer choices for 1 are either warm compresses,
Aspirin and Rice syndrome.
Rice syndrome.
Okay. You sure about that?
Yes.
100% sure.
Yes.
It is correct. You are correct. I just want you all to get into the habit of reading all the answer choices. The nurse's notes for 9 a.m. The client has received the first dose. Oh, that should be ceftriaxone. Healthcare provider consulted on the prescription of aspirin and advised on holding the drug administration. Scheduled for myringotomy tube insertion. The child is resting more comfortably, although still irritable. The caregivers report the child has accepted a small amount of fluids but continues to refuse solid fluids, and the caregivers are educated on the procedure. Anything concern you about the vital signs?
Yeah,
Did his
no great
temperature
fever.
go, compare it, did his temperature
Yeah.
go up or down?
Stay the same.
Okay. Well, it went up a little, didn't it?
Yes.
What about his blood pressure?
It's low.
But he's only 2 years old,
Yeah, it's
so
okay.
it's normal. His heart rate went down a little, his respiratory rate and his pulse ox. So are we concerned about any of those?
The
Not
heart
really.
rate and the
Heart
respiration
rate.
rate came down a bit.
But
Yeah,
he's 2
rate
years
against
old.
His temperature.
The temp.
Yeah, the temp is a little high and he's getting ready to go to surgery. So the healthcare provider ordered IV acetaminophen 120 milligrams every 8 hours. So here's your lab results. Anything stand out to you?
The white blood cell.
white blood cell.
Yep. Is that it?
It's high.
White blood cell.
The
Really?
platelets are normal.
Yeah.
The platelets are 362 and the normal is 150 to 450.
400.
Is the potassium okay?
Potassium is good.
Okay.
Sodium is good.
Potassium's
Fluoride is good.
okay.
Sodium is good.
Everything okay except white blood cell.
Everything is okay except the white blood cell count. Yes.
Infection.
But he has acute otitis media with a fever. So are we really, really concerned?
No, it's
No, it's
expected.
It's
But it's
expected.
pretty high and he's fixing to go to
It's
surgery.
exaggerated. Yep, it's very high.
And he's getting ready to go to surgery, right? So the client is diagnosed with acute otitis media. Which of the following complications are associated with the condition? It's a select all that apply.
Meningitis.
Meniere disease, tympanic membrane preparation,
Meningitis.
meningitis, A, B, D, E,
G.
And G.
G. Yeah.
Okay. So it's actually
A, B, E.
A, E, and G. So Meniere's disease has to do with your inner ear and causes vertigo. We typically do not see that in children. It can cause meningitis. It can cause tympanic membrane perforation, right? Because it's in the eustachian tube right there at the tympanic membrane. And it can cause mastoiditis. Does not cause tonsillitis. And the tympanic membrane perforation we talked about.
So what's the answer again?
It's A, E, and G.
Okay.
Professor, I have a question.
Sure.
So the NCLEX will give us the normal ranges?
Yes.
Okay. So that's mean we don't have to learn that? We don't have to memorize the lab?
I wouldn't say you don't have to learn it, but NCLEX is giving normal ranges. But if you don't understand like what it could cause if it's out of range, then that could be a problem. So I wouldn't say you don't have to learn it.
Okay.
And for some of your routine ones, they may or may not give you the answer, the normal ranges.
Okay.
But one of the things I want you all to get used to doing is, and students do this, they just want to know the answer. What's the answer to this question? But you can see I can change the question and make those other answer choices correct, right? So learning why they're incorrect is also very important as to not just finding what's the correct answer, knowing why those other answer choices are incorrect is very important too. So that's reading those rationales, because you saw I've changed a couple wordings to several of these questions, and I kind of throw that out there at you so that it gets you to really think and apply what you're learning.
Okay. Thank you so much.
You're welcome.
Can you please explain D?
D is Meniere's disease, and it's a neurologic, and it has to do with the inner ear, and it causes vertigo and dizziness. Typically does not occur in children. It's not a common disease in children. And it's unrelated to otitis media.
It's not going to relate it with otitis media?
I'm sorry?
It's not going to relate it with the otitis media?
No, it's not related to acute otitis media. And it occurs in older adults more often.
Okay, thank you so much.
So your case study continues at 3 o'clock. The client underwent his myrigotomy with tympanostomy tubes in the left ear. The procedure was completed without complications. He's alert and responsive postoperatively, though he's still a little irritable. So what's making him still irritable? Is that normal for him to be irritable?
Could it be the fever?
It could be the fever, but have any of you had any surgery before? And you're coming out of anesthesia?
Anesthesia, yeah.
And you're kind of loopy, right?
Yes.
We can say we as adults know what it is, right? Oh, it's due to the anesthesia. I'm kind of loopy, whatever. Kids can't verbalize that, so they're going to be irritable, right? So
they don't understand what's going on with them.
Ma'am, I didn't
No, I'm
hear
sorry.
you.
I was just saying that they don't understand exactly what's going on with them after the anesthesia. Yeah.
Yeah. So is that an expected finding? Is my point. It's expected for a kid. Now, if I'm irritable or an adult is irritable, it might not be expected for them post-surgery, right? But for a kid, it's expected. So I'm not really concerned about that still, right? Ear drainage noted, and the tympanostomy tube is in place. Here's his vital signs. Have we had improvement or changes? His temp's gone down, right?
Heart rate went down.
Yep. Well, his heart rate was probably elevated because he had a fever too, right?
Yes.
And he was anxious and going to surgery. So his temperature came down because we gave him Tylenol, right? He had surgery. We kind of fixed the problem. Remember, a fever is a symptom of something else. So this would be a matrix question where you'd have to put a check mark or bring the question over to that section. So the caregiver statement, I will gently pull the earlobe upwards and outwards before administering ear drops. Is that they understand?
No understanding.
Yeah, they're not. No, we don't do that. How do we do it?
Down.
Downward, then and back.
Down and
back.
Downwards and backwards. I will wait for the tympanostomy tubes to fall out independently.
Understanding.
Yeah. Yep. I will insert cotton balls in the ear canal when bathing the child.
No understanding.
No understanding.
Why not?
Yes.
You cannot insert
We should
cotton
not
balls.
get water in the ears, right?
Yes.
I will avoid submerging the child's head in water while bathing.
No
Understanding.
understanding.
That is
Doesn't
understanding. You just
understand,
submerge.
right?
It is?
Avoid
Oh,
understand.
avoid. Sorry, I didn't see that part.
Yeah,
Sorry.
see, he does. It's understanding. They will
Mm.
avoid submerging the child's
Yeah.
head in water. I will notify the healthcare provider of any persistent fever.
Yes.
Yes,
Understanding.
understanding.
Yep. There's your answers. So, day 2, nurse's notes at 8 a.m. The client, can whoever has the background noise mute?
Hey. Professor, just mute everybody.
I don't want to mute everybody. I'm going to mute who is. I want to be able to have you guys interact if you have questions. Because it's hard for me to monitor the chat and look at my slides to help you. So, all right. So day 2, the nurse's notes at 8 a.m. The child is awake and alert, demonstrating increased comfort following the procedure. The caregivers report a significant improvement in the child's irritability, and the child is now eating small amounts and drinking fluids well. Minimal ear drainage is noted, and the caregivers express understanding of the following plan and are reassured about caring for the tympanostomy tubes. So, has our child improved?
Yes.
Yes. Yes. Some improvement. There's still some little changes. So, what would be when we're evaluating this patient? The nurse is reviewing the client's admission note and comparing it to today, day 2 at 8 a.m. You would highlight the findings that indicate the child's condition has improved. So, awake and alert, is he improved or has he changed? Or stayed the same? He was awake and alert and irritable when he came in, right? Demonstrating increased comfort following the procedure. Is that an improvement?
Yes.
Yes.
So you would highlight that. The child's irritability has improved, so we would highlight that.
I like that too.
He's now eating small amounts and drinking fluids well. We would
I
highlight
like that
that.
too.
Minimal ear drainage. We didn't really have ear.
We don't have it.
We didn't have drainage in the beginning. The caregiver expresses understanding of the following plan and are reassured about caring for the tubes. Yes. His fever, it's about the same, right? I think it was 100. We could go back to the first slide. He was 100.8. So he's improved, right?
Yes.
At 99.
Yes.
Oh, I'm sorry.
Yes.
Yeah, he at 99. Blood pressure, his heart rate has come down. So we're good, right?
Yes.
So that would be your instructions, and we just highlighted it. References, and that is all I have. Any questions, comments, concerns? Nothing? Are y'all staying on for is there another one after this?
No, this is the last for today.
Oh, this is the last one for today? Okay.
Yeah. Professor, I have a question.
Yes.
So I was going through my questions for this Naxlex, and I got these questions wrong. Let me show you. I'm still not understanding why.
What questions?
Oh, it's in the chat. I'm gonna have to put it in the chat.
Yeah, because I'm not gonna either that or
the photos.
what is it related to? Did you read the rationale? Does anybody else have any questions while she's typing that?
I don't know why it kicked me out.
Okay.
Here it is. So the first one is this one with well, this one's also for adult too. Is that okay?
It's what?
For adult as well. I sent it.
I'm not sure. Where did you send it?
In the chat.
In the chat?
I can only do it in the chat.
Okay, I cannot make that bigger. And I cannot see that. A nurse is caring for a client with
open angle glaucoma.
Okay.
Oh wait, no, that wasn't it. Yeah,
Which
that one I got right. The other one was about the. Oh, here it is. The 3-year-old with the aortic irrigation. That's the one. I'm sorry, I sent you the wrong one.
A nurse is caring for a 3-year-old client who is scheduled for what?
Experience. What is it? The scheduled for a OTIC irrigation.
Otic irrigation.
Otic irrigation. Okay. I can't write. Y'all, I'm old and I already have reading glasses. I can't see all of that. So, what is it? What? Which of the following actions should the nurse take?
Yes.
Okay. So the first one says.
Professor, try to click on it. When I click on it, it's become bigger.
I clicked on it and it's not.
Oh, okay. When I click on it, it's bigger.
Oh, here we go. Okay. I had to download it. Okay. Pack the ear canal tightly with a cotton ball. Well, think about that. If you're irrigating the ear, you're not going to put a cotton ball in it.
Right.
Warm the irrigation solution to 98.6. That's the correct answer. Why do you want to not? You want to make it room temperature or body temperature. What's our body temperature? 98.6, right?
But I've
If you
never heard of that. I don't know,
if
like,
you
what the irrigation is like. Is that flushing it out?
Oh yeah, we irrigate ears all the time. People get not rodents, but insects in their ears. I sleep with a pillow over my head because years ago I had to take a cockroach out of somebody's ear.
Oh.
That was alive, okay? So I
But you
sleep with a
don't put the
pillow.
flow like in the middle of the ear. That's the tympanic membrane. I know I normally, and that
But
wasn't
you're
up.
irrigating. Okay, so when you're irrigating, you're pulling down the ear
Right,
and
down and out.
and you're irrigating it with a solution.
Right.
We also irrigate the ears for earwax, and we put Debrox, or we put I can't think of the name of the eardrops that we use that will break up the wax, and then you gently irrigate it with like a 30 cc syringe, and you put an IV catheter tip on the bottom or on the end of it, and you gently, very slowly, and you put a kidney basin next to it and let the fluid flow out.
Right. So wouldn't you toward the tympanic, like where the eardrum is?
Not if
Or
you do it
not?
correctly,
You're
and
not
not if you
supposed
do
to?
it slowly. If you use hot water or you use cold water, you can irritate the eardrum. You don't want to do it because you direct the flow of irrigating solution toward the tympanic membrane. If you direct the flow towards the tympanic membrane, you can rupture the membrane. If you push it too fast,
Oh, so I mean, so where would you put it? Upward then? Where
well,
would
no,
you
you kind of
irrigate?
push it. You put it's a catheter. So, an IV catheter,
Mm-hmm.
you take the needle out and you put the actual catheter on the end of the syringe. I
Okay.
think we use it's a 10 cc syringe. And you pull up the warmed or the room temperature. We don't warm it. You don't ever put anything in the microwave, but we
Right.
just make sure it's room temperature.
Okay.
And you're not going to get cold saline, or you're not going to put it in the microwave. You use tepid, warm, cool, room temperature solution, and you pull the eardrum down and you point the catheter. I call it a catheter because that's actually what it is, but it's directing the flow, and it's kind of downwards, and you have the patient tilt their head. I don't know if you can see me. Tilt their head down, and you put a kidney basin here, and it just flows out into the kidney basin.
Oh, okay. So it's not in
If
the
you're
middle of
so
it.
if you didn't know the correct answer to that, let's talk about test taking strategies. Well, you're not going to
Yeah.
put a cotton ball in if you're going to
No.
irrigate something, right?
Right.
I could see maybe where you're going to pull the pinion upward and outward if you weren't sure. That could be a possible answer choice. But what
But
can
I
happen?
thought for upward and outward, that's only for adults. For kids, it's
I
down
know.
and out.
I'm just going through saying how I could see where you might want to answer a particular way since you didn't
Oh, okay.
get the
No, I
answer
was
choice
between
correct.
4 and 2.
What?
I was between the 2 answers, so it's like 4
Right.
and 2.
Right. So I'm just giving you tricks on how you can narrow it down. So we
Okay.
already eliminated 1. 2, you weren't sure about. 3, you went ahead and eliminated it, but I can see how somebody might pick it. And then 4, why could we eliminate that one directly? Because if you irrigate something and point it directly at that tympanic membrane, you can rupture that membrane, which you don't want that. So you should be able to get rid of 1 and 4 automatically because of that.
I didn't know about that because I always do it. And
Do what?
I always squeeze like the ear thing, this bulb. I squish it towards the middle of my ear.
What bubble? What? I'm not sure what you're
A
talking.
bulb, you know, those irrigation,
You kind of suction out your own ears?
Yeah, sometimes. And I always put the flow of it in the middle of it. I didn't even know that.
So you irrigate your own ears with the bulb syringe?
Yeah.
I'm surprised you don't have hearing problems. Because how can you see what you're doing? Because you can. Okay, so here's another tip. Don't answer questions on how you practice, see, do, or you saw, because that's incorrect. You don't want to irrigate it and point it towards the tympanic membrane. You can rupture that membrane.
Okay. Yeah, I didn't get that.
So if I was you, I would be watching what you're irrigating in your ear because you can't see that. When I irrigate a patient's ear, I can see. I can't see all the way back to the inner ear, but I can see where I'm pointing that fluid.
Right. Yeah, I always thought it was okay, so I'm glad you're letting me know.
Nope. You can rupture that eardrum.
Okay.
Because that tympanic membrane is your eardrum. So, all right. If nobody else has any more questions, I'm going to say goodnight.
Thank you.
Thank you,
You're
Prof.
welcome.
Good night.
You're welcome.
Professor.
Thank you, Professor. Good night.
You are welcome. Good night.
Thank you, Prof.
Thank you, Prof.
You're welcome. Yay, congratulations. You passed your NCLEX.